All right, starting with our first tumor here, this is Glioblastoma Multiforme, and this can present as a butterfly glioma. Each of these videos, we kind of do the same thing we did in the pediatric brain tumor video. We'll talk about where it comes from, how severe is it, the location, what are we going to see on a microscope. Sometimes I'll put in some macroscopic findings if they're high yield, some molecular findings, associations, and presentation. So the GBM, or glioblastoma multiforme, this is actually going to be the most common primary brain neoplasm, so it tends to get asked about frequently for that reason. Now, in terms of its origin, it's from astrocytes. So you might be remembering there's another tumor that we talked about in the pediatric brain tumor lecture, and that's going to be the pilocytic astrocytoma. And because these are both derived from glial cells, they're going to be GFAP positive. Okay, so just remember, GFAP positive. I don't think I included that here. I think I included it on the previous slide, but just write that into your notes so that you remember that. So pilocytic astrocytoma, glioblastoma multiforme, GFAP positive. Because this tumor is derived from astrocytes, it's going to come from neuroectoderm. So as long as you remember the origin of the cell, if you can remember where these cells come from, you'll always know the embryonic tissue derivative that it's from. Okay, and just like we said with medulloblastomas in pediatric patients being very aggressive, having increased risk for drop metastases, in adults, the glioblastoma multiforme is the aggressive tumor to remember. Okay, and this one typically, once patients are diagnosed with GBM, usually the median survival is only 10 to 12 months. Okay, so this is a very poor prognosis, unfortunately. Now, the location of this tumor is mostly going to be in the cerebral hemispheres, and it has this tendency, especially in board questions where everything is usually classic, it has this tendency to cross the midline through the corpus callosum. Okay, and so you get this shape here that kind of looks like a butterfly. That's why it's called a butterfly glioma. Okay, so this is very classic for GBM. Usually we'll see this, in the frontal lobe or the temporal lobe, or intraparenchymally somewhere in the brain. It is really important, like I said in the last video, that you understand the microscopic findings for a lot of these tumors, because this is how a lot of the questions are going to come up. They're going to show you the histology, and they want you to recognize it on step 1. So I'll show you this in a second, but microscopically, what we're looking at are these very poorly differentiated primitive cells. This is very similar to what we talked about when we talked about medulloblastoma. I kind of told you that, when you have aggressive tumors, they're going to use certain words to describe the tumors. This is just a general rule of thumb. There might be exceptions to this, but in general, when you see terms like anaplastic, poorly differentiated, very immature cells, right, primitive cells, these are all words to describe a very aggressive tumor because it's replicating very quickly. It's very difficult to control. And so these are terms you might see used in conjunction with like a GBM or medulloblastoma. Now, the classic microscopic finding is going to be the pseudopalisading necrosis with neovascularization, peripheral vascular proliferation, and mitotic figures. So again, mitotic figures is another one of those terms where when you see it, you start to think, okay, this is an aggressive tumor. This is all going to be, you can see all these nuclei here, and we're in a pretty low magnification, so you can see the nuclei are very small, but you can see they're kind of arranged in this pattern here, right, all around here. So this is the nuclear pseudopalisade that they're talking about. Okay, it's almost this arrangement of all of these basophilic nuclei. Okay, and then in the center we have this kind of empty eosinophilic space. This is the necrosis. Okay, so this whole space is the necrosis that you see, just this kind of this pink tissue here with no nuclei. So you have this pseudopalisading of the cells around the necrosis, and this is very, very classic for GBM. Okay, let's talk about one of the molecular targets here. So there's an overexpression a lot of the times in the epidermal growth factor receptor, EGFR, and this is not isolated to GBM. This is going to be seen in small cell lung cancer. A lot of different cancers will have overexpression of EGFR. There are certain treatments that can target EGFR, like erlotinib, for example, which is not particularly high yield. But the thing to remember about EGFR is, number one, that it's associated with GBM, but then number two, what is EGFR? Because these are the kind of details they like you to know for step 1. So you should know that this is going to be a tyrosine kinase signal transduction system that is responsible for growth of the cell. So what happens is when there's overexpression of it, there's uncontrolled growth. Okay, so that's kind of how you can make sense of that. And then again, the presentation is relatively nonspecific. In general, in adults, you're usually going to see new onset seizures. It's going to be a patient that has never had a history of seizures. Now they have seizures, some new focal neurologic deficit, or worsening headache. But that's going to be classic for a lot of the different forms of the primary brain tumors.